Introduce our first speaker for the year, Dr. Raymond Pashun. Dr. Raymond Pashun joined our faculty in January of 2025 and most recently appointed the medical director of the 7D CCU. He's an assistant professor and critical care cardiologist at University of Michigan. He previously completed training in critical care medicine at Stanford University School of Medicine, following his cardiovascular disease fellowship at Northwell Health, North Shore University Hospital, and Long Island Jewish Medical Center. Upon completion of his training, he was a critical care cardiologist at NYU Langone Health for over 3 years. In addition to his clinical practice, he is passionate about medical education, particularly through the utilization of simulation-based modalities. He serves as the simulation content planner for the NYU Critical Care Cardiology Symposium and serves as faculty at the University of Minnesota Critical Care Cardiology Education Summit. He is an active member of professional societies, including the ACC, AHA, SCCM, and Society of Critical Care Cardiology. When not in the CCU, Ray enjoys spending time with his wife, Mary, and 3-year-old golden doodle, Chewy. Please join me in welcoming Dr. Pashun this afternoon.
Thank you. Thank you for that kind introduction, and thank you everyone for coming to my talk. I know a lot of you probably already know me, but for those of you who haven't yet, I know I've only been here for a short period of time, but my name is Ray Pashun, and you'll most frequently be seeing me in the CCU. Today, I happen to get dressed up for this occasion. So my talk today is involving a particular interest of mine that I've been able to explore a little bit over the course of my training and career. So I'm going to talk with you today about cardiopulmonary resuscitation and potentially what are the future options for that in terms of our monitoring and augmentation modalities. So, CPR potentially without the guesswork is the future CPR by real-time physiology. And I realized after the fact, I forgot to put in a disclosure slide. I have no disclosures to tell you about. So the agenda overall for this talk is we're going to do a brief review of the current state of cardiopulmonary resuscitation, a little bit of history for those interested. Then we'll talk about some of the advances in some of our physiologic monitoring and what those parameters might look like. And then we'll finish off with some of the CPR augmentation modalities that we do have that tie into a lot of these, the physiologic framework for cardiopulmonary resuscitation and their successes or limitations of them. So to kind of ground us all, I wanted to present a fairly routine sort of case that potentially we encounter in day-to-day practice. Not too much in the way of background information. 59-year-old gentleman with a history of ischemic cardiomyopathy, hypertension, and type 2 diabetes is visiting family and suffers cardiac arrest. So it's a witnessed arrest and bystander CPR is initiated. It might look something like this. If you can't recognize that individual up there is actually me pretending to have an arrest of sorts. I was at a conference and tasked with pretending to have an arrest scenario to get the crowd involved. So surrounded by family and friends, having an arrest suffered. So the next steps is we all reach for the playbook, essentially. We have our ACLS guidelines that we all know and love and utilize on a day-to-day basis, potentially depending on where our practice settings are. But overall, for the most part, it's fairly algorithmic based, and we are just kind of doing the usual steps, going down, checking the rhythm, applying shocks, applying medications as needed, and then reassessing where we're at and deciding whether or not we're continuing or there's no guidelines for how to adjust built into this algorithm. There's some subtle hints if you read in the right-hand column about some potential monitoring parameters, but there's no guidance or potentially true guideline, true guideline directed options that we currently have for how to adjust this algorithm otherwise. So with that, for our patient that we're talking about, bystander CPR was initiated, EMS arrives, they note ventricular fibrillation, they attempt defibrillation unsuccessfully 3 times and decide, given he's going to probably need a higher level of care, move him rapidly to an academic medical center. High quality CPR is in progress. The emergency room staff takes over, continues this course of therapy, continues to receive epinephrine, potentially some amiodarone, lidocaine as needed, and then potentially additional defibrillation. But essentially, this is more or less with the inclusion of pulse checks, this is the routine that we are set in as of right now. So the problem is that traditional CPR is very algorithm driven, and we don't have potential feedback parameters or other ways to monitor and adjust built in currently. And the survival rates for in-hospital and out-of-hospital cardiac arrest still remain very poor. In-hospital arrests with approximately 20 to 25% survival, and out-of-hospital with approximately 10% survival. So let's take one step back. How did we truly get here? So back in 1874, a physiologist, Moritz Schiff, decides he's going to work with a canine model and figure out when their hearts stop, when they go into cardiopulmonary arrest, how am I going to bring them back? And he decides opening the chest and doing cardiac massage provides adequate blood flow and perfusion to bring a certain percentage of them back. And essentially for 85 years, that is technically the standard and specialized centers for addressing cardiopulmonary arrest until 1960. The Journal of the American Medical Association publication that is put out describes potential doing closed chest cardiac massage and its potential viability and success. In the middle photo is the essential diagram of how it was recommended to be performed back in 1960, and the actual arterial line waveforms that were monitored in these patients who had arrested. And believe it or not, in this paper, there was a 70% rate of return of spontaneous circulation. So it seemed like things were great in 1960, and now we're sitting here about 65 years later, and we still are using some very similar algorithmic approaches. So what's going to tie into a lot of this is what underlies the act of cardiopulmonary resuscitation, and from a physiologic standpoint. And I'm sure most of you are acquainted with and familiar with this predominant cardiac pump theory, where applying chest compressions to the thorax, in particular above the sternum, compresses the heart against the vertebra behind it, allowing for compression of the ventricles and subsequent cardiac output to sustain perfusion and some of the other targets that we will talk about shortly. There are other aspects of the overall physiology of CPR that potentially comes into play. One of the main alternative physiologic approaches to CPR, or physiologic concepts behind CPR, is the thoracic pump theory, whereby it's less the actual compression of the heart against the sternum and vertebra itself, but rather the actual changes in the intrathoracic and intra-abdominal pressures in order to propel blood forward, as well as get venous return into the heart. And the heart is viewed more as a passive conduit in this sort of approach. And it's not one size fits all. There's potential variations and aspects about certain patients or physiology that potentially play more into one scenario versus the other. That being said, the goals of CPR, we're trying to maintain systemic perfusion with the main goals of maintaining our coronary perfusion as well as our cerebral perfusion in order to achieve ROSC and favorable neurologic outcomes. Ideally, also, if we can identify the underlying etiology of why the arrest occurred. Some of the additional aspects of the physiology of CPR to be considered include cerebral perfusion characteristics. We are talking about maintaining cerebral perfusion, but we are very much focused on our chest compressions and appropriate chest wall recoil. That being said, cerebral perfusion characteristics are not necessarily built into the algorithm that much. And when you are doing these chest compressions, you can potentially have depressed venous return, and also the positioning of the patient doesn't necessarily allow for outflow of the venous structures from the head, ideally. And this was looked at in studies previously at different positions of CPR, whereby the intracranial pressure can actually be decreased with a head up position to 30 degrees. And I bring this up here because it will play in down the line in this talk. Additional physiologic considerations are what we're doing from a ventilatory standpoint. Hyperventilating or too much positive pressure ventilation potentially will increase your intrathoracic pressure, leading to reduced venous return and decreasing your cardiac output overall. Additionally, hyperventilation can also lead to decreasing your partial pressure of CO2 in the blood, and subsequently lead to cerebral vasoconstriction, which, yes, might combat some of the intracranial pressure aspects, but it will still potentially be unfavorable from a neurologic recovery standpoint, potentially. So that's kind of the foundation that we have to kind of move forward into our monitoring and then subsequent devices that we'll look at. So some of the more current monitoring strategies that we do have, or maybe have a little bit more familiarity with at this current standpoint. Again, we're going to maintain systemic perfusions. What are our best windows into that? We've talked about maintaining coronary perfusion. That is one potential target. Also go into the end-tidal carbon dioxide monitoring, how that plays into things, as well as diastolic blood pressure. And just to bring everyone's attention, the guidelines maintain a 2B recommendation. Not, we're not talking 1, but we're not saying 3, don't do this. So it's still a little, you'll see this is the common trend for a lot of this, is all of these aspects have potentially 2B guidelines, but there's, I think, a way that we can incorporate them into our practice. So starting off with coronary perfusion pressure, again, one of the targets of providing adequate cardiopulmonary resuscitation. As we know, the coronary arteries do fill during diastole and during CPR diastole, and that essentially is achieved by the gradient between the aorta and the right atrium, manifested in this equation here. So the predominantly diastolic blood pressure minus the right atrial pressure will generate that gradient and that coronary perfusion. And in early studies, it was investigated using essentially invasive catheters placed at the time of CPR. Study team would rush in catheter, so these parameters, and see if more favorable outcome, their results kind of correlate with what our targets are, increasing the coronary perfusion pressure corresponds with an increase in circulation. Again, in initial studies, that initial coronary perfusion pressure comparing in not achieving return of spontaneous circulation and achieving return of spontaneous circulation, if it was higher at the initial onset of CPR initiation, there was a higher propensity or higher likelihood of achieving return of spontaneous circulation. And also, over the course of cardiopulmonary resuscitation efforts, the maximal coronary perfusion pressure that could be obtained correlated with success, and being able to maintain or get to a maximal coronary perfusion pressure of greater than 15, you had a greater than 50% likelihood of achieving ROSC in those patients. That being said, this is sure useful feedback for physiology guided CPR and maybe some degree of ROSC prediction, but it's obviously invasive and impractical, and people aren't going to be rushing in to put these catheters in place in the midst of a cardiac arrest that can get very turn into a very sticky situation potentially. So there has to be some other modalities that we can potentially utilize in order to achieve these goals. So end-tidal carbon dioxide, something that's fairly common, and I'm sure a lot of you use it in day-to-day practice, essentially is monitoring the exhaled CO2 that we have. So carbon dioxide being a byproduct of our aerobic metabolism, essentially it leaves our tissues as a byproduct, returns to the lungs via the venous system, and then is eliminated through our alveoli, and that's where our sensor comes in to detect it. The sensor here, for those that might be a little unfamiliar, attached to the end of this ET tube and giving feedback in the capnography waveform, essentially. And this essentially, as we'll see, is useful in the fact that it will correlate with your overall cardiac output and your perfusion metrics. So end-tidal CO2 and CPR can be used for real-time feedback. It has been shown in multiple studies to correlate with cardiac output, coronary perfusion pressure. This is just demonstrating that with appropriate AHA guideline chest compressions, you can mount higher end-tidal CO2s with appropriate CPR. The end-tidal CO2 will also correlate with the probability of ROSC. So if you're able to target at least greater than 10 millimeters of mercury, as investigated in some small studies, you can potentially have a higher rate or likelihood of achieving spontaneous circulation or return of spontaneous circulation, as opposed to if you're unable to. It also potentially can be served in a potential, if you have a longer code episode, potentially inform some degree of prognosis and futility after a period of time. So there were essentially kind of two studies, one initially smaller one, and then a larger out of hospital cardiac arrest patient population, looking at what the end tidal CO2 was after about 20 minutes of cardiac arrest. And in survivors versus non-survivors, the proportion having a higher end tidal CO2 after 20 minutes had a significant proportion of a better rate of return of spontaneous circulation. And in a further analysis in this larger out of hospital cardiac arrest group, they found a cutoff of approximately 14 millimeters of mercury. If you were unable to achieve that or maintain that after 20 minutes of CPR, it was almost all but likely that you were not going to achieve successful ROSC at that time. So sure, maybe it sounds somewhat promising, but obviously there's caveats to all of these things. These have been predominantly observational studies, and there is still no consensus guideline or recommended target for how we utilize it during cardiac arrest. Even in the guidelines, they suggest at least 10 millimeters of mercury, but ideally greater than 20 if you can obtain it. And I think that we kind of saw the data that was extrapolated to achieve or to have that published. That being said, other things is it has to be utilized with an advanced airway predominantly to make sure that these are appropriate readings. And there's very subtle alterations potentially in values with some of the medications we potentially give during cardiac arrest, but just to make note of that. In general, this is a fairly non-invasive modality to utilize in cardiopulmonary resuscitation, but looking at the AHA registry data, it's overall underutilized. Only 4% of cardiac arrests in their close to 30,000 patients that they looked at in general utilize this. They did note that in provider teams and in institutions that did utilize it, they overall had more favorable rate of return of spontaneous circulation. And those that used end tidal CO2 with even more granularity in their reporting capabilities had favorable survival to hospital discharge and neurologic outcomes if they were able to maintain that end tidal CO2 greater than at least 10 millimeters of mercury. So one potential option there as well. Then the kind of last one in this section of monitoring is the diastolic blood pressure, which, as we kind of saw previously in the equation, that is a core component of providing coronary perfusion pressure. And so maintaining a diastolic blood pressure generally greater than 25 to 30 millimeters of mercury is overall the target to at least to make sure that we are maintaining coronary perfusion. And it can potentially serve as a marker of CPR quality and does have association with survival and favorable outcomes. That being said, this was extrapolated from a very small, predominantly pediatric patient population. Looking at the greater than 1 year old cohort that was investigated, there was kind of the inflection point in that 25 to 30 millimeters of mercury diastolic blood pressure range, with the optimal being around 34, that led to increased probability and success of survival during cardiac arrest. And also, they looked at how maintaining that diastolic blood pressure associated with outcomes, and if you were able to maintain that, it was associated with more favorable outcomes down the line. That being said, is that practical? We're talking about now an arterial line essentially to monitor diastolic blood pressures during cardiac arrest. At the very least, we have studies that indicate that if you do quality CPR, your diastolic blood pressure generally is around 30 when averaged out. So at the very least, high quality CPR remains, a still main cornerstone of our care. The other part of that to consider is it may have some practicality in the fact that 59% of all in-hospital cardiac arrests are in the ICU, a large proportion potentially having arterial line access of some kind. So it can potentially be used as a feedback mechanism in this setting when it is already there. I'm not suggesting we kind of pause all resuscitation efforts to place an arterial line to get that. Obviously, that's wasted time, but just a consideration. So those monitoring approaches are, I would say, a little bit more known and potentially new or up and coming modalities of real-time monitoring. One is in regards to the cerebral perfusion, the regional cerebral oximetry, which utilizes the near-infrared spectroscopy device, the NIRS device, for those of you who haven't seen it. This is the monitor that would give you your output and your readings on there. The are just below it. This is in of the probe and ultimately on the patient. It would be on the both sides of their forehead for monitoring. But this is essentially evaluating their regional hemoglobin oxygen saturation in a normal patient being around 60%, and for values corresponding with poor cerebral blood flow. And this can potentially be utilized in CPR quality of CPR from a neurologic or cerebral perfusion standpoint, the end-plate stability, prognostic impact, as well as neurologic recovery. Again, small studies, but it has been shown that a higher regional cerebral oxygen saturation has more favorable rates of return of spontaneous circulation, demonstrated in the smaller study of out-of-hospital cardiac arrest patients, where the cerebral was have return of spontaneous circulation, which was closer to 20 to 25. And then in a larger kind of meta-analysis and of these studies that looked at this, there was an overall favorable outcome in terms of achieving return of spontaneous circulation. That being said, again, there's no clear cutoffs for this. We have kind of our normal range, but that's not necessarily the ideal range for CPR or CPR in the masses potentially. But the extremes of them do potentially have predictability, where less than 25% on your cerebral oximetry portends to a very low rate of return of spontaneous circulation and likely poor outcomes long-term, as opposed to maintaining potentially in that normal range or greater than 65% even, you have a greater likelihood of achieving ROSC and a good outcome. The next thing to bring up is transesophageal echocardiogram, or in this context, resuscitative TEE, which is something that is being looked at in increasing capacity. So we all know in our cardiac arrest scenarios, we try to utilize transthoracic echo to try and evaluate for underlying etiologies and trying to troubleshoot and improve our efforts. But that is often limited by acoustic windows, motion that's going on, just not having enough room to facilitate things being in the right place at the right time, and as well as contributing to potentially longer compression pauses as you're trying to get those views. So and just a kind of a little bit of a cartoon to demonstrate this, you're in the middle of a cardiac arrest and, you're rushing in with your echo machine. This is obviously a much smaller echo machine than we're all probably accustomed to, unless you have like a butterfly or something, but, can't get anywhere near the chest. So you've got the probe on the face for some reason. But resuscitative TEE potentially serves to obviate a lot of these issues to help facilitate diagnosis, minimize pauses, and improve the AMC, or the area of maximal compression when you're performing CPR. And some brief examples of that is in some cardiac arrest scenarios, where it still remains unclear should efforts continue to be pursued to continue the resuscitation efforts. TEE is potentially a relatively fast way of obtaining further information in this patient. In panel A, with the double yellow arrow, we see in the ascending aorta coming just above the aortic valve, we see a dissection flap that occurred in this patient, which was subsequently also noted to have a hemorrhagic pericardial effusion delineated by the star. So it potentially has some degree of diagnostic utility. As well as I was mentioning, the area of maximal compression. In our cardiac pump model of CPR, we want to compress over the ventricles to generate that cardiac output. So the last place you want to be compressing is over the LVOT or ascending aorta, and basically eliminate all of your cardiac output, as was occurring in this other patient, which TEE was able to help guide. In terms of using transesophageal echocardiogram to minimize pauses, in small studies, it has been shown to minimize the overall duration of compression pauses from 19 seconds with transthoracic to 9, which is essentially equivalent to standard CPR without using any of these modalities. And using transesophageal echocardiogram to identify the area of maximal compression also leads to improved stroke volume and cardiac output, as delineated in this graph, with the upward deflection getting closer to the area of maximal compression. It's been mostly limited in terms of the human data looking at hemodynamic impact. There's been a largely porcine model of data that has been evaluated to this point, but in terms of the hemodynamic impacts, it does lead to significant increased cerebral blood flow when appropriately identifying the area of maximal compression, increases in diastolic blood pressure, and end-tidal CO2. So kind of all of those markers that we are concerned about in the course of a cardiopulmonary arrest. So shifting a little bit from some of the monitoring parameters now to how can we potentially augment CPR efforts beyond just our, two hands and an adequate supply of rotation of compressors to cycle in. How can we augment beyond, or can we augment beyond what we already do? And so there's a host of devices out there. I'll touch on these each in time. Some of you might have some familiarity with some of these, but I'll introduce them all. So the first one, active compression decompression CPR. A lot of you probably see the Lucas device that's hanging out in a lot of corners of this very hospital, which essentially has a suction cup here that gets lowered to the patient chest and then essentially starts compressing and decompressing. A little bit more to the physiology than just that. And then the rescue pump is actually a handheld version, different manufacturer, but essentially it achieves the same physiology. And so the goal of this is to utilize the cardiac pump and thoracic pump model. So you are getting active chest compressions and ventricular compression, but you are also utilizing suction cup capabilities to have active chest wall expansion, reducing that intrathoracic pressure to achieve greater venous return. And this was the premise of these devices was based on a study in out-of-hospital cardiac arrest data that showed that increasing the rate of chest wall recoil actually had favorable impacts on survival. Looking at the data for these devices overall, in terms of the hemodynamic parameters, yes, it does have favorable impact on cardiac output, cerebral perfusion, and myocardial perfusion overall when looking at it. But what about studies or outcomes in a predominantly out-of-hospital cardiac arrest patient population, less so in hospital in these studies? There was no clear delineation one way or the other, just mixed results that did not necessarily clearly portray a survival advantage one way or the other. And so that is one caveat to take note. Similar but different, the mechanical compression devices you might think look the same in some ways, but the Lifeline arm compression device is actually just a straight piston that compresses up and down. There's none of the suction cup or suction capabilities to have that more active chest wall expansion. And then this device on the right, the Zoll AutoPulse, is actually a circumferential band that compresses the entire thorax, which is utilizing potentially more of the thoracic pump model of CPR. And so these are two other devices that have been looked at and utilized in various ways in the field and in hospitals. Ultimately, over multiple meta-analyses and sequential assessments of the data, there's no demonstrated impact on return of spontaneous circulation or survival or neurologic recovery with these devices as compared to our standard CPR efforts. Switching gears a little bit from kind of what we generally think of with CPR in terms of strictly compression assistance is the inspiratory impedance threshold device, or the rescue pod impedance threshold device. And this is essentially a valve that connects to either a bag valve mask or preferentially endotracheal tube. And it's essentially trying to optimize the thoracic pump model of CPR. So we don't want to have high intrathoracic pressure because that will then lead to diminished cardiac output. And in particular, we don't want to have higher than needed intrathoracic pressure when we have chest recoil, because that will then potentially limit that venous return. So this essentially limits the inflow of air during chest wall expansion, essentially. Does it work? No. In isolation, it doesn't work. So that's the one caveat. Using this device by itself does not show any favorable benefits whatsoever. There is the combination of this device with the initial device I had mentioned, the active compression decompression device, that does have favorable rates of return of spontaneous circulation and subsequent survival, ultimately to hospital discharge and survival with neurologic recovery. So this is, highlighted actually, or at least I'm bringing it to your attention in the guidelines that this also is a 2B indication that there could be, if people are, if staff is trained appropriately, that this could have favorable benefit in a cardiac arrest setting. And if you look just below it, class 3 is using that impedance threshold device just by itself. So we don't want to see that in isolation. Moving on to some other devices that are probably less noticeable by people is the interposed abdominal compression CPR. This is the device to facilitate it, and in terms of a one-man operator scenario. It can also be employed to have 2 compressors, one over the chest and one over the abdomen, but basically works to alternate chest and abdominal compressions, increase your abdominal pressure, leading to increased venous return and therefore cardiac output ultimately, in an effort to, again, maintain perfusion and achieve ROSC. Overall, looking at this, there was essentially no benefit in the out-of-hospital cardiac arrest population. There was some slight potential trend towards favorability in the in-hospital studies. And again, the guidelines essentially effectively reflect that. Again, we're dealing all in the 2B space here today, where it can be potentially utilized in an in-hospital setting if sufficient personnel are trained in its utilization. This one is a little on the newer side and being increasingly studied as time has gone on, the automated head thorax up positioning CPR. And a lot of people focus just on the positioning aspects of it, but it's actually the entire system of care, essentially. So it is the active compression decompression device, it is the impedance threshold device, and this ELIGARD device that does the head and thorax up positioning. And the whole reason for that head and thorax up positioning is to enhance venous return and reduce intracranial pressure to try and optimize our CPR efforts. So essentially, when it is employed, at the outset, the head is raised to 12 centimeters and the thorax is elevated to 8 centimeters. And at the end of 2 minutes, it gets up to 24 centimeters at the head and 12 centimeters at the chest. And it continues in that state until further decision is made. And this, in an out-of-hospital cardiac arrest setting, has been fairly promising in terms of rates of return of spontaneous circulation after its employment. The rates significantly increased in a single center study. It has also been particularly advantageous in non-shockable rhythm patients out of hospital cardiac arrest. And when it's employed earlier on in the cardiac arrest, it potentially has more favorable benefits down the line. So again, trying to achieve our return of spontaneous circulation and ultimately survival. There we go. And so lastly, and this one could potentially be a Grand Rounds topic all on its own, but I will kind of do a glancing blow for it. Extracorporeal cardiopulmonary resuscitation, or eCPR, essentially in the midst of your cardiopulmonary resuscitation efforts, cannulating to VA ECMO to completely support the patient, provide full cardiac output and systemic perfusion. And this has been looked at in 3 major trials to this point, the ARREST, INCEPTION, and PROG out-of-hospital cardiac arrest trials. The ARREST trial was the positive one out of the University of Minnesota, looking at predominantly shockable rhythms, and patients were cannulated very rapidly within an hour of determination that they were refractory arrest, and they had a significant survival advantage. A kind of similar study or similar design study that did not have favorable or as favorable outcomes was the INCEPTION trial that people bring up as the kind of rebuttal to the ARREST trial. Also looked at shockable rhythms and did not have as favorable an outcome overall. That being said, again, without getting too into the granularity, there were some caveats to this, that the patients were not cannulated as rapidly as the ARREST trial, and that could potentially have further impacts long-term. And then in the PROG out-of-hospital cardiac arrest trial, there were non-shockable rhythms were incorporated as well, which could have potentially also skewed results to some extent. But there was a trend towards favorability, but not significantly different. So let's take this. So again, dealing with the 2B space, it is still, a 2B indication recommendation for potentially considering this in patients if the institution and personnel are trained and ready to employ this device in a select patient population, essentially. That being the main takeaway, that this is potentially a utilized device and scenario for patients in a very select subgroup of the population, potentially, based on the data that we have right now. So kind of tying this all back and bringing it back to our 59-year-old gentleman at the beginning, how can we employ some of the things that we've just talked about earlier to try and maybe impact his course to some extent? So for our patient, our EMS personnel arrive and are able to initiate potentially an active compression decompression device with impedance threshold device during out-of-hospital cardiac arrest. He was in a shockable rhythm. They provide those shocks as indicated, but with potentially no significant return of spontaneous circulation. In the setting of maintaining these devices, moving him to a higher level center for further consideration and monitoring. If you apply some of these monitors, you might be able to see the end tidal CO2 is on the lower side, 8 millimeters of mercury. Cerebral oximetry sats are 35%. So something is wrong with our resuscitation efforts, and we are not optimized. You can potentially troubleshoot the devices yourself, adjust the active compression device at that time, or take over and do standard CPR. But if properly employed, can utilize resuscitative TEE to confirm where the compressions are occurring. We can localize that the area of maximal compression is potentially in an inappropriate spot over the left ventricular outflow tract and adjust the device appropriately. And with subsequent improvement in your perfusion targets, he still remains in refractory arrest, but if we are still within the appropriate time intervals, he is the actual average age of the patients in the arrest trial with the actual refractory arrest that the patients in the arrest trial had, and would potentially be a candidate for eCPR based on some of these other markers, using these targets that we've talked about to say that, hey, our CPR efforts are appropriate. We are achieving the targets that we want, and he potentially could go on to have a favorable survival. So kind of tying this all in conclusion, standard CPR metrics still remain necessary, but they could potentially be insufficient due to patient heterogeneity and not having the full data at the time that you're performing these maneuvers. Things might get lost in the shuffle, and you might not necessarily be doing all the things that are right for that patient at that time. I know it's a compressed and stressful time period, but if we have the devices and tools potentially to give us some sort of a signal, we should utilize them. So physiologic monitoring, some more than others, are useful at providing insight into our performance. Obviously, the invasive strategies, less so, but end tidal CO2, cerebral oximetry, and TEE potentially can be useful in guiding resuscitation efforts. There is some evidence to support a physiology-guided approach, and there's still ongoing evidence being explored, but it does have trends that show that we can improve our efforts at cardiopulmonary resuscitation by using a lot of these devices to improve our rates of return of spontaneous circulation and neurologically favorable survival. The circulatory augmentation devices should be employed appropriately. People should be trained appropriately and know how to utilize them without sacrificing time from the patient perspective. But some of the more favorable evidence is with the active compression decompression device with the impedance threshold device, as well as increasing evidence for the heads-up performance of CPR. And potentially, again, it's been I think 65 years since the advent of closed chest cardiac massage. We're potentially due for some sort of new scenarios or new ways to approach our cardiopulmonary resuscitation efforts in order to optimize our outcomes. This is potentially what I hope is kind of the beginning of a shifting paradigm from more of the algorithm and just following the standard guidelines to trying to actually assess and have feedback for what we are doing at the bedside in order to provide better outcomes for an already sick, high morbidity, high mortality patient population. And with that, I want to say thank you. Thank you to all my past prior mentors that I still maintain relationships with. Thank you to everyone here being as welcoming as everyone has been, and the phenomenal team that I've been very fortunate to be a part of for the past 9 months. And then lastly, thank you immensely to my biggest cheerleaders. Pictured is Chewy, my 3-year-old golden doodle, and not featured is Mary. She did not want to be photographed. But let's turn it over to questions. Thank you for having me.
Thank you, Dr. Pashun, for that enlightening, fantastic talk. I do have one question, then I'll open it up to the floor. Kind of an out-of-the-box thought, and I'm sure I'm not the first person to think of it. Has there been any thought or looking into utilizing wearables in this kind of space? So if a patient who has out-of-hospital cardiac arrest is wearing something, a watch, a Garmin, or a ring, somehow syncing that to an iPad that, somebody has when EMS arrives to provide that real-time feedback if we're looking at physiology parameters, maybe an app or something, or I don't know, a provider wearing a wearable activates an app and that gives them real-time feedback on how they're doing.
Yeah, not that I'm currently aware of. I don't know if anyone else in the crowd has further information regarding that, but not that I'm aware of or came across in some of the background work for this. But I think that is a very interesting topic. Yeah, I'd have to do more investigating.
Wonderful. Any questions from the audience? Excellent.
Yeah, thank you. That was fantastic. I have a couple of questions. Like one is, do we have this equipment available to us with the active compression decompression device to apply, and do our house officers know how to apply it? And then the second question is, when we take ACLS, they're suggesting that we use the end-tidal CO2 device so that we can have feedback as to the adequacy of the compressions. Is that not something that you would recommend?
No. So the first point, we do have the active compression decompression devices. They're stocked throughout the hospital. The familiarity and facility with which our house staff potentially use them, I think, is always an ongoing question, and it does require orientation and instruction. And if you only use it once in a while, you potentially lose that. So it's potentially better housed with a primary response team, if you will, like a SWAT team or such, because they would be more facile with the appropriate utilization, employment, and minimizing chest compressions overall. At least that's been my experience with utilizing these devices. So yes, we have them. Yes, we have people around that are well trained in utilizing them. I would have to refrain from answering on the house staff side of thing, because at least when I was a house staff, I didn't know how to appropriately use a lot of these things. So I think that there's potentially a learning jump there. In terms of the end-tidal CO2, yes, I completely agree with using it during CPR. That is one of the feedback mechanisms I think that can be used, and it is actually hidden in the top part of the algorithm that is part of the ACLS guidelines, that you can use that as feedback. But again, they don't provide true guidance or guidelines for what those numbers should be, or how to extrapolate if you've been in the middle of a cardiac arrest for 45 minutes and the end-tidal CO2 has remained 5. That is likely you're not going to achieve ROSC likely in that circumstance. So I think it is useful. I think these feedback mechanisms should be used. End-tidal CO2, cerebral regional oximetry is also easy to apply and utilize. I don't know how accessible it is to all the areas where cardiac arrests currently occur. But no, I 100% agree with using end-tidal CO2 and using that to tailor your chest compressions and resuscitation efforts, because if you're in their loose guidelines under that 2B recommendation, it's at least 10 monitoring. And if you're not achieving that, potentially adjusting the compressor or adjusting your compression efforts, or and then ideally greater than 20. And then ultimately, if you're not able to sustain that, poor prognosis, unfortunately. And if you do have a sudden jump in end-tidal CO2, that's actually a marker of potential return of spontaneous circulation. So it actually potentially precedes achieving a pulse, actually. So it is a very useful marker and should be used. Yes.
Great talk. Is there any evidence, clinical evidence, that any of these efforts improve 30-day survival, or like the patient walks out of the hospital with an intact brain?
So some of them in terms of neurologic outcomes, yes. In particular, some of the ones that we mentioned. So monitoring and achieving some of these targets have a more significant trend to favorable neurologic outcomes. The end-tidal CO2 device during CPR, the regional cerebral oximetry, the active compression decompression with impedance threshold device, as well as now that in addition to potentially the heads-up positioning CPR has had some implication towards that. So it's not robust data, it's not randomized trial data, but it is a potential marker that it can potentially provide more benefit for, again, if we're dealing with out-of-hospital cardiac arrest patients, they've only got a 10% survival rate as it is. In hospitals, 25% as it is. So, I mean, we're kind of grasping at straws to some extent to try and just make incremental changes and try and prevent, or at least, have a positive outcome where otherwise there would not be. Yes.
Great talk. I'm not sure there's data for this, but did you see any sex differences in terms of the outcomes? And are you aware of any race or ethnicity-based differences in outcomes?
I am not readily aware of any racial or ethnic differences in outcomes or gender or sex-based differences based on these studies.
Could you please review the evolution of thinking and the current recommendations for respiratory support during CPR? You just talked about compressions.
Yeah, so I guess in terms of like our bag valve mask strategy and everything.
Bystander CPR versus CPR. Used to breathing.
Yes. Yeah. I don't have that readily available off the top of my head. But I mean, at least the way that the pendulum has been swinging for at least bystander initiated CPR, at the very least starting chest compressions and restoring circulation is the primary maneuver up front with a little bit of a lesser emphasis on providing mouth-to-mouth resuscitation up front. I think depending on, there's a lot of other factors that go into this. There's wide variability in EMS response times throughout the country. We know the West Coast does better. We know the East Coast does worse. And so that does factor into it, the rapidity with which deployment can occur to potentially have an advanced airway and such. But, ultimately, I think if you're without having, again, readily accessible data off the top of my head, in terms of if you're a bystander CPR and you have nothing else around, if you don't have an AED and you don't have any other mechanisms to support, at the very least chest compressions need to be initiated. But, if this is going on for a period of time, you should have ventilatory support because that will be a major component. But I don't have finer data to reference right now.
Any other questions from the audience? I'll ask one last one, which is, do the American Heart Association guidelines differ dramatically or in any way from national guidelines in other countries? And do they have other ways of assessing physiologic response that we don't necessarily incorporate?
It's a great question. Off the top of my head, I don't believe that there's a significant difference between the guidelines, but I would have to confirm that. But for the most part, they're pretty much lockstep.
Wonderful. Well, thank you again, Dr. Pashun. Thank you.
Thanks for having me. Oh, thank you. Oh, thank you. How are you?